Thank you for all the professors. And now session number 13, titled by Plenary Session 2. So please, I need from the chairpersons to come on the stage. Professor Ali Abbasi, Professor Fahmi Aimara,
Second session, the third, Professor Leszek Czupryniak, Head of the Diabetology and Internal Medicine, Department of Medical University of Warsaw, past President of Diabetes Poland, past member of the Executive Committee of European Association of the Study of Diabetes. He will talk to us about autoimmune diabetes of adults, adult type 2 diabetes.
Thank you very much, Mr. Chairman. Thanks to all of you, the organizer, Professor Ines Schaltut, for inviting me here. It's not my first time at this wonderful meeting. I see the program is getting thicker and thicker, and my congratulations for the organizers for having it such a rich program where repetitions are inevitable, but on the other hand, when I went through it, all aspects of diabetes will be covered. My name is Leszek Czupryniak. I came from Poland, and in fact I was the executive member of AASD, European Association for the Study of Diabetes. For many years I have been responsible and still am involved in postgraduate education programs run by the AASD, and together with Professor Schaltut we also had two courses organized together with AASD here in Cairo. So for me it's a privilege to be able to speak to you. I will have more than one opportunity to present various areas of diabetes. I will start with the topic I was asked to cover, which is somewhat an orphan topic. We talk a lot about drugs, of course. We talk about obesity, comorbidities, complications. This is something we don't talk too much, I feel, unnecessarily, undeservingly, because this is the area which has no new drugs for any autoimmune diabetes, but our knowledge on the role of autoimmunity simply grows. And I will try to briefly present it. But before I move to the topic, I just to somehow want to make myself more familiar. For you, Poland probably sounds more exotic than Egypt for us. We all in a primary school, in our curriculum, we have this book to read, which was written by one of our top writers, Bolesław Prus, and the title is Pharaon, as you can see. The book was written in 1895. Poland was not officially existing at that time. It was partitioned between Prussia, now Germany, Russia, and Austro-Hungarian Empire. But this is an exciting book about the power and the love. This is the story of Ramses XIII, probably a fictitious pharaoh, but as you all know very well, at the second half of the 18th century, the whole world was fascinated with the discoveries which were made in Egypt, and as I and all of us learned very recently, are still being made today. The book was turned into a movie. This is the main protagonist. Every female in Poland was in love with him, I can tell you. The film was made in 1967, and it had Oscar nomination as the best international movie, and it was also shot in Egypt. As you can see, it's about love and power here. The story is said Ramses XIII dies and loses his fight with all the priests who wins and become next pharaoh. So this is a nice story about power. That's why Egypt, apart from being a holiday resort and holiday destination with all ancient history, we all learn a lot about your past when we are just kids. We read it when we are like 12 or 13. So just to make Poland and Egypt a little bit closer. Okay, let's move to this autoimmune issue of diabetes. If we look at any classification of diabetes, this is what you can find in ADA classification. There are 4 main types, as we know: type 1, type 2, gestational, and other specific types. And there is not a word here in this classification about type 2 diabetes, which might be of autoimmune origin or autoimmune mechanisms. We know that these types overlap, and this is where we find out, this is where we put autoimmune type 2, somewhere between type 1, type 2. There used to be a constant discussion whether so-called LADA, latent autoimmune diabetes of adults, is a separate entity. Now we believe it's not much separate, it's rather a continuum, but that continuum, as was rightly said by the previous speaker, doesn't mean we need specific treatments for specific patients. So that makes the issue of individualization of therapy even more important. The discussion started really on the classification and on finding out how much in high resolution we should look at types of diabetes. Started a few years ago. This was one of the first papers which reopened the discussion of classification of diabetes from 2016. The paper was written by eminent American diabetologists. The last person here is the past president of ADA. And in this paper you may find a figure like this, showing clearly intertwining of various elements we measure or we don't measure in our patients, like obesity, autoantibodies, or C-peptide if we choose to do so, but I would argue it's not much necessary. We'd rather should focus on autoimmunity markers. But we do not measure HLA, DQB1 genes, for example, or other genes like FTOs. We also do not measure T cells activities. But somewhere here, from pure insulin resistance to insulin deficiency, mostly caused by autoimmunity, there are patients which we call LADA patients, those latent autoimmune diabetes of adults. And somehow they are more prevalent in that region of the world. As you know, there are 2 main capitals of diabetes. One is Indian subcontinent, India, Pakistan, Bangladesh, and the other capital is Arab world, with all your countries here, where prevalence is high and still rising. This is a paper from Bahrain showing, if you look at the bars, try to show it with the mouse. If you look at, hardly. If you look at this left-hand bar, this is the typical type 1. Oh, thank you. This is typical type 1 patients. This bar here are typical type 2 patients. But the middle ones here, these are patients who look like type 1, but they have no autoantibodies, but low insulin production. And this is the group which looks like type 2. They are obese, and they have autoantibodies. This paper is very interesting because it describes population, as you can see in the title, of very young people below the years of 20. So up to, if you calculate the number, up to a third of patients with what we would call type 2 diabetes, just looking at the person, have some autoimmune markers. That means they would probably move to insulin faster. This is a traditional thinking. And insulin, of course, in obese patients is a challenging treatment, as we know. So if we move on to what was next in this story, this was 2017, AASD meeting in Lisbon in Portugal, and this poster presentation attracted a lot of attention because this was the first time, and this now is discussed at almost every meeting where we talk about type 2, not even classification, but simply how we should treat type 2 patients. This has already been turned into a paper in the Lancet. This was the first publication which clearly showed that if we look what they did, this is a paper from Scandinavia, you must have heard about it. They took 15,000 newly diagnosed patients. They chose six very simple variables, and for 4 years they measured their disease progression, treatment, and development of complications. And what they found out, that there are 5 subtypes, and now this is really being used in the presentations and in the papers. There are 5 subtypes of diabetes, and here among the adults, you see 6.5% of patients with severe autoimmune diabetes. But there are also patients who are insulin deficient, and they also might have some signs of autoimmunity. They might have had it before diabetes was diagnosed, or they may actually occur after the diagnosis. These names are now used as well: severe insulin deficient, severe insulin resistant diabetes, and mild obese-related and mild age-related diabetes. Those mild word is probably not the proper one, because there's nothing like mild diabetes. The very classification is not that interesting. What is interesting is that they associated the type of diabetes with the clinical features and the risk of complications. And that might guide us when we choose the treatment, for example. Patients who are insulin resistant are much more likely to develop kidney disease. And this, as I said, was developed into a paper which was published in the Lancet not even 2 years ago. And they presented here, those are 5 clusters. These are these names of these subtypes. And if you look at these graphs here, this shows how quickly patients need insulin. This is this insulin deficient patient, this is this autoimmune diabetes, so they quickly move to insulin. But if we look at the complications risk, these are the patients who develops kidney failure or kidney complications, and this is cluster 3. This is this insulin-resistant group, while autoimmune diabetes is here, not high risk of nephropathy. So this partly explains why we see, if you work in diabetes long enough, you must have seen patients who have diabetes for 20 years and nothing much happens really, and they are still on oral treatment, and they don't really strictly follow any diet. And there are patients who just have diabetes for 5 years and already develop severe vascular complications. So this might be partly an explanation. And looking for autoimmunity should help us choose the treatment to tailor it more simply better to for the patients. So what is this LADA diabetes? If you look for definitions, not much has been published since 2005. This is an unofficial diabetes definition, but most often cited. You can diagnose someone with this subtype, let's call it, of diabetes. If we have someone who's diagnosed after the age of 30, have any autoimmunity markers, most often we measure anti-GAD and autoantibodies in this age group. They do not need insulin for at least 6 months after the diagnosis. That's it. That's pretty simple. But in fact, I guess in clinical practice, when I see someone who's 27 years of age and needs insulin after 5 or 4 months, we may also call them LADA. In fact, it's just a slow developing type 1, but we must not omit it. And we still see patients who are ineffectively treated with oral agents for 1 year, 2, 3, 4, 5 years, before anyone thinks maybe this is a type 1, in fact, maybe this is autoimmune type 2 diabetes. And the most misleading factor is body weight. If we had the money and recommendations to measure autoantibodies in all newly diagnosed type 2 patients, you would be surprised how many obese patients have markers of autoimmune reaction. And that should simply tell us, okay, just giving them like sulfonylureas is probably not the best option. The discussion goes on. This is the paper from July this year from a number of Italian researchers, as you can see, a few famous names like Antonio Ceriello or Giuseppe Mattarese. How much of an autoimmune disease? The question is asked here. And they published that sort of figure, that these are the 7th variables we can look at and try to differentiate clinically who's type 1, who's type 2. There are, however, issues which we don't measure here, again, like systemic low-grade inflammation. We also, I don't think we should measure C-peptide every time. You would be surprised how many patients with long-standing type 1 diabetes have still detectable C-peptide levels. Where I work, we usually decide to measure C-peptide only in a challenge test. So just measuring fasting C-peptide is not much of a use for differentiating of the type of diabetes type. If anything, we should do a glucagon test and see the reaction after this sort of stimulation. Again, going closer to your region, you saw in Scandinavia 6.5% of patients who are deemed to be type 2 and they were autoimmune diabetes. You saw 30% in patients from Bahrain aged below 20. These are the data from Qatar. This is also the recent study from 2018. And they just measured beta cell autoantibodies and other autoimmune diseases. This is an important indicator of autoimmunity, of course. In type 1, in type 2, children and adolescents. Again, Arab world is probably the best, unfortunately, the best place, especially the Gulf region, where type 2 in adolescents and children is already not that infrequent. We have single cases in my country, for example, but we do start to see it with growing obesity in children, while in the Gulf it's much more frequent. And if you look here, if you look at this, this right-hand part here, those children and adolescents who were diagnosed with type 2 initially because they were obese and they were insulin resistant, as you can see here, a third again, 29%, had markers of autoimmunity. So the younger the person with diabetes, regardless of the body weight, we might say, should be suspected of autoimmune disease. But in the adult world, it's probably, fortunately, not 30%. If you look at this paper published 3 years ago about LADA prevalence, it is shown here using various markers, but mostly GADA, as you can see. It's somewhere between 5 to 12% of prevalence. So I guess in everyday life, we may expect that about 10% of our type 2 patients might be with autoimmune diabetes. So what should make us more suspicious if we do not measure autoantibodies? It's again the age, it's again the ketosis, which is not as frequent as in type 1, but may occur, of course. Decreased beta cell function, which, as I said, would best be seen in a glucagon test, but the body weight is something which should tell us something, but we shouldn't simply take it like a 0-1 definition. If you're overweight, no way, you mustn't. It's impossible, you have autoimmune disease. It's quite opposite. We started, I can tell you, in my department, we started to measure autoantibodies in almost every newly diagnosed type 2 person below the age of 50. And we find out that really obese people do have high titers of antigen levels, and we simply start to talk at least about insulin much sooner with them. There are a number of papers you may find about etiology, because it is a fascinating area. Why type 1 classically is developed by children and adolescents and the symptoms occur rapidly. There is no doubt it's diabetes. Again, I may recall your heritage. As you know, it's the papyrus, Ebers papyrus, discovered by Georg Ebers. This is one of the first ever description of type 1 diabetes. It hasn't changed. But why, again, the same mechanisms goes very slowly in some people and leads to the development of diabetes when people are in their 20s, 30s, or 40s, but could be even in 70s. The oldest person I've seen with autoimmune diabetes was the lady with newly diagnosed diabetes who was 78. And she was clearly having, we would say, type 1 or LADA diabetes. So if you look at these papers, in many papers here, that's one of them. there is a clear association between body mass index and autoimmunity. The higher the body mass index, the more likely someone is to develop classical type 1, the lower we might expect LADA. However, if we look at body weight and patients with low and high anti-GADA titers, some scientists argue it is of clinical value. I am not so much convinced. We've seen patients who rapidly progress to insulin with just doubled or 3 times higher anti-GAD titers, and patients who had thousands of units of anti-GAD antibodies, and they just stay on just diet and some DPP-4 inhibitors. This is what we often use as an oral treatment. That, in the same paper, you may find this analysis, so that we may draw this line as a clear relationship between titer of antibodies and BMI, and then further, we can associate anti-GAD antibodies with HOMA index as well. So this is also the inverse relationship. But what does it mean to the patients? Because that's the most important thing. Well, that means that the vascular risk, complications of vascular, the risk of developing vascular complications is different in these patients whom we call the LADA patients. This is the paper, again, from Nature, as you can see, so as high as you can get, from 2017, showing prevalence of retinopathy here, and left part of each figure here is patients who have diabetes for less than 5 years, and this is for longer than 5 years. So in those who have diabetes for longer than 5 years, and this is when we might expect complications, in fact, we may see that retinopathy in LADA patients is simply higher. You may also see it in nephropathy, not so much in neuropathy, and absolutely no difference in cardiovascular disease. So that's not a surprise. We would rather, like in type 1, expect microvascular complications. So who is under suspicion? Who should you look at it carefully and think, maybe I'm wrong, maybe I think it's a type 2, but it's a slightly different type of the disease. So this should be a person who, that's another concept, who has 2 out of these 5 conditions, and this sort of analysis has 90% of sensitivity and 71 specificity for LADA diagnosis, so not that bad. And these 5 are age of diagnosis below 50. That's one of the reasons why we started to measure in my department autoantibodies in patients who are diagnosed below 50, who have clinical symptoms at diagnosis, whose BMI is basically normal, who have concomitant autoimmune disorders, this is a very strong factor, and have poor diabetes control with oral agents. If anyone, 2 out of 5 of these variables are present, then you should really think about LADA. How we should treat it? So, well, the treatment, as it says in the most important papers, the best therapy has not been identified. It might be insulin, but we still feel that perhaps this is a subtype or a subtype of type 1 where insulin might be just too strong, or it might be too difficult to use insulin in these patients. There are papers showing that the higher titer, the sooner insulin is needed, but as I told you, clinically, I'm not that much convinced. If anyone is overweight or obese, metformin is always a good option. Somehow, incretin-based therapy has started to be the favorite ones for LADA patients with little evidence. I just show you one piece of evidence in a moment. Pioglitazone could be used, while sulfonylureas should not really be considered in these patients. So incretin agents, we have little data here, especially on injectables, but the most recent addition to our drugs are once-weekly GLP-1 receptor agonists. As you know, there is dulaglutide, and we are going to have worldwide, I guess, semaglutide. And what Eli Lilly did with dulaglutide, they analyzed from the whole program they had, a world program with dulaglutide, they identified patients who had GADA antibodies. They were positive. Not many of them, as you can see here, about 8%. 2.4% had high titer, 5.3% had low titer of anti-GADA. And they just looked at the efficacy of dulaglutide. Does such a drug acts better or worse in patients who have autoimmune type 2 diabetes. And as we might expect, the response is slightly worse. This is HbA1c lowering effect. Is slightly worse with dulaglutide in patients who are GADA positive. But if they were divided into patients with high or low titer, those with low titer responded really the same way as GADA negative patients. So maybe there is some difference in this activity of autoimmune process.
You need more time, sir?
I have 2 more slides, please.
2 more slides, okay.
2 more slides.
دقيقة كمان يا ابني.
With conclusion, which is usually important. If any one of you falls asleep, then please wake up for the summary. So GLP-1 receptor agonist might be an option, and especially in patients who does not seem to have full-blown autoimmune reaction, for example, also do not have concomitant autoimmune diseases. So the final understanding of this coexistence of this complex or a high number of elements which contribute to diabetes pathogenesis could be drawn like this. That this is a beta cell function or dysfunction, as we all know, which plays a role in type 2 diabetes development. This is insulin sensitivity or resistance. And it all can be somehow connected with autoimmunity. And we probably should start to be thinking with general rise in autoimmune diseases in modern world. It's not just type 1 which is rising, many other diseases, thyroid diseases are rising. So perhaps our environment facilitates this sort of diseases to be developed. So we probably should stop thinking about just beta cell dysfunction, insulin resistance. There should be another question in our mind, okay, and what about autoimmune markers? Couldn't this patient be an anti-GADA patient? So just to summarize, autoimmune features, as I told you, could be found in around 10% of adult type 2 patients. Across the regions, probably slightly higher in your area. The leaner the patient, the greater is the likelihood of LADA, especially with concomitant disease disorders. If I see anyone with vitiligo, not so much thyroid, but if you see vitiligo, then absolutely it would be, he would be anti-GADA positive. If in doubt, refer to anti-GADA antibodies rather than fasting C-peptide level. It will not be very helpful. And treatment, insulin or incretins plus metformin is probably the best option as of today. Thank you very much. Shukran.
Thank you, Professor. Thank you very much. We allow one question only because we are lack of time. Please. Microphone هنا.
Thank you very much for the nice presentation. My question is basically to manage as a clinician, like this cases, we need a simple test to guide us. Is there any correlation of the diagnosis of LADA with the high sensitivity CRPs? Is there any study can be helpful so we can use a marker cheaper than anti-GAD65?
Yeah,
because there is a correlation before between high sensitivity CRPs with the MODI types. So if you can comment on that, please.
Yeah, that's a very good question. There have been studies done, but no clear correlation have been found, even with high sensitive CRP. That would be very useful. The subclinical inflammation is really subclinical in diabetes. You have to refer to other agents you may assess, but it's really for research purposes, adhesins or von Willebrand factors, which tell us about endothelial damaged by an inflammatory status, but not CRP. We don't have, the cheapest still now is anti-GAD antibodies. We pay for it. It of course depends country from country, probably lab from lab. But when I order through a hospital, I can tell you we pay only €5 for one measurement, so it's not that expensive. But if you do it in the lab in the city, if someone wants to do it privately, they would pay about €20. So this is the discrepancy of the price. But in younger people, we somehow force them to do so because it really tells us, especially if it looks like type 1 and patient does not accept it. Or if they have a job and we think he will need insulin and they have a job where insulin might be a problem, like truck driver, we also make, oh sorry, it's better if you pay. It's like, I like the comment or the summary from the last speaker that perhaps people should spend a little bit less money on their hairstyles or in the restaurant and pay a little bit more for lab tests if it is not covered by the government. But no easier tests. The problem with anti-GADA, anti-GADA antibodies is that the titers changes. But the oldest, again, the patient with the longest duration of diabetes when we detected anti-GADs were 20 years. So we even found out now when anyone has diabetes longer than 15 years, and we doubt whether it's type 1 or type 2, and we want to be convinced. You may even find autoantibodies in such a long-standing diabetes as well. We know very little about this autoimmunity business, in fact, in the adults. We still learn.
Okay, thank you very much, sir.
Thanks a lot.
Now we finish this session. Now Sanofi Symposium will start now.